Broadcast is now starting. All attendees are in listen-only mode.
Hey, good evening, everyone. Glad you can all make it tonight. Thank you so much for your time tonight. We're gonna have get started here in just a sec. We have Dr. Pablo Wagner and Dr. Emilio Wagner on the other line. They have a wonderful presentation that they've put together that they're going to go through. Please feel free at any point to type in questions in the chat box. I'll be monitoring the chat box, the question box all night, and we can be sure to get your questions answered. If not through the presentation, but by the end of the presentation. So I'm going to go ahead and flip it over to Dr. Pablo Wagner, and he's going to go ahead and get started. Again, thanks for all your time being here tonight. Hey, Dr. Wagner, can you hear me? Hey, Dr. Wagner, are you still muted? Can I unmute you? Mute you? Hold on. There we go. We should be able to hear you now.
Okay, thank you. That was it. You were good controlling myself. Okay, good.
Fantastic.
So hello everyone. I'm Pablo and with Emilio here. So the Wagner brothers will talk about the promo technique and rationale. So we'll say a few words about the measuring rotation, and at the end we'll present you some cases, and hopefully we'll make some things clear for you. And if you have any questions at the end, we'll be very happy to help you with that. So to start with the pre-op planning, we really now use only the AP plane X-ray. As you probably know or you've heard before, the axial sesamoid view was the one that at the beginning we were using, trying to standardize or to objectively measure the rotation of the metatarsal, but we really got many opinions and feedback that it was not really a reliable X-ray projection. So we really changed to the AP plane X-ray, and we'll tell you on how do we estimate the rotation with just that one plane X-ray. Obviously, the gold standard for this rotation measurement is the weight-bearing CT scan, but probably you would agree with me that you will not take a CT scan for all your bunion cases. So we are now estimating 3 levels of rotation, as you can see in on that slide. It's mild rotation, moderate rotation, that is by far the most common, and severe rotation. And we're separating them in level 1, that is the mild deformity or mild rotation, between 10 and 20 degrees of pronation. And how does it look at an X-ray with this level 1 rotation? You can see that on an AP foot view that you're seeing now on the slide, you have that red line that represents the joint line, and you have the white line that represents the metatarsal condyle. So you see that there is a distance from the red line to the beginning of the white line here, where the pointer is. So from this point, where the white line makes an angle here, to this point here, where the red line makes an angle. So this distance is what we are really measuring now, and we'll explain you how. So this is a level 1 rotation, so a patient with a mild deformity, and this is what we are doing now. So if you look at on your left, you see, I will repeat, the white line represents the condyle here, and the red line represents the joint surface. So if you measure the distance where the joint line ends, that is here, where I have the mouse now, and you measure that distance to this point where the metatarsal condyle starts, if that distance is more than 1 millimeter, we can estimate that this metatarsal head, or this metatarsal, is between 10 and 20 degrees of rotation. We think, and we have really seen that with our residents, that it's really a very easy rotation measurement, and it's reliable. We will show you in the next few slides a comparison with a weight-bearing CT scan that really show that this measurement really is representing a mild degree of rotation. So this is a magnified view of the same thing. So you take the joint line apex here, measure the distance from that point to the point where the condyle starts, and that distance, if it's above or more than 1 millimeter, that represents a mild rotation, 10 to 20 degrees. So level 2 rotation, it's between 20 and 30 degrees of pronation, and this is an example here. So you have a metatarsal that has a joint line here. You have the condyle, the metatarsal condyle here, and we'll do the same thing. We'll measure the distance between that apex, where the joint line ends, to the point where the metatarsal condyle starts. If that is 1 millimeter or less, that is a level 2 rotation or moderate rotation. There is another case here on your left that where you can see that you have a joint line depicted with the white line here, and it follows with the metatarsal condyle without having any step. So we should say here that is obviously less than 1 millimeter, because we cannot really measure a distance between the condyle and where the joint line ends. But it's not a perfectly round line. You will see, and we call it a discontinuous or asymmetric round line. The same thing happens with this example on the middle. And here at the right side, you have a very small bump step or line step, however you want to call that. And level 3 rotation is the severe rotation. Well, you have the more above or more than 30 degrees of pronation. We have here one example here where you can see that is really a absolutely round head. You cannot really differentiate where the joint line ends and where the condyle starts. And that's why this image, we try to draw a circle, and it really, the joint surface and the metatarsal condyles are in a continuous round line, and you could draw a circle here, meaning that this metatarsal is pronated above 30 degrees. So how do we know this? Probably you already read or have seen me presenting this paper of Yamaguchi, but the last thing we did, we compared different degrees of pronation with weight-bearing CT scans. And as you can see in this slide here, on your right side, you have a coronal view of the forefoot where you can see the sesamoid facets. And if you measure that angle between a line following the sesamoid facets and the floor, in this case, you have a 19 degrees of rotation. Now, if you look at the X-ray of the same patient, you'll see that you have a joint line here with a less than 1 millimeter step here following the metatarsal condyle. So this is, I'm sorry, I measured it. This was 1 millimeter. So with 1 millimeter, you have 19 degrees of rotation. So if you have 1 millimeter or less, we say that there is a level 2 rotation, and we just say it's between 20 and 30. Obviously, this is a 19-degree rotation, and you have a 1 millimeter. So we just assume that with this case, we would do a 20 to 30 degrees of rotational correction. And being this probably the worst case scenario, because this is a case that is exactly in the middle of both levels of rotation. I tried to draw the lines here. So on the right, you have the floor line, and the white line should be on the sesamoid facets. This line should be a little bit down here. I don't know why it moved. And here I drew the line following the joint line here, and the same white line following the metatarsal condyles. And as I said before, this step is a 1 millimeter step. So I think this, and we are now writing that publication. So you should see that that publication soon appear on the literature, comparing this weight-bearing CT scans and the AP foot view. So some other thing that we wanted to show you is that the TMT instability, it's real. We have seen it. More or less 10% of our patients have this TMT instability. And it's really something we should take a look at, because obviously it will be a patient that is at risk of having a relapse of his bunion. So if you see any step, any sag incongruity, you should really go with a TMT fusion or a lapidus, not with an osteotomy. So this is the case. It's really a little bit old case, but as you can see on the left side, that's a pre-op view. On the middle, you have a scarf that I would say it's well aligned with good correction, with obviously some malrotation, but we know that scarf does not correct rotation. And if you see the 1 year post-op view, you see that the IMA angle, it's greatly increased. So you see a relapse of that foot. And this is obviously an increased rotation of this metatarsal, of an increased intermetatarsal angle. And you can see, and on the next slide, you will see a magnified view of the TMT. There is a TMT joint incongruity. I'm sorry, this is, no, I was mistaken. This is not my case. This was a case from somebody in the US that sent it to me. This is a magnified view of the TMT joint, where you can see here, following the metatarsal, so how there is a step or an incongruity with the cuneiform, with the medial cuneiform. So if you draw a line there, this is the metatarsal line, and this is the cuneiform. If you don't magnify this view, probably you will not see that. It's a very small detail, but in our minds, it's very important. So this is the pre-relapse view with a straight line, with a metatarsal line following the cuneiform. It's really different with that. And this is another case. Yeah, this is my case. And as you can see, it's much more evident, the TMT incongruity on both sides. Probably even more evident on this left foot. As you can see, there is a cuneiform, medial cuneiform here with the metatarsal, the metatarsal bone being medially translated. So this is not a case for an osteotomy. So going into details regarding planning and technique. So we already talked about rotation. A brief summary. So the current rotation angles we are measuring, it's this 1, 2, and 3 levels of rotation. We are not really seeing patients with this amount of rotation. So probably you will see that in the new in the new tables of the promo, you will not see this column here. So it will be just these 3 columns. So regarding the soft tissue approach, it could be medial or dorsal. You can do it like minimally invasive. This is really how we do it. It is a 3 centimeters incision, and for the aching and the exostectomy, we just do poke incisions and we use the Shannon burr. If you do it open, that's perfectly okay. It's the same incision as but for a scarf. And if you want to do a aching osteotomy, it's really approximately a 6 centimeters incision. So I would just go a little bit more faster through these steps because probably you already know this. So the first step is to drive a wire that is perpendicular to the metatarsal, like you see in this X-ray, and parallel to the floor, as you can see in this drawing. After that, after you have that first wire in position, you slide your positioning jig through the 0 hole. Then you add a second wire that you slide it through the rotation hole that you previously measured on your patient, and you will have an image similar to this picture on your right down side. Then through the wire you just inserted, you slide the osteotomy jig in place through the hole that you already chose from your table, and you fix this jig distally on the metatarsal equator. There is something important here, that if your proximal wire is not on the equator, then your distal wire should be at the same height on the metatarsal. So just give me 1 second. Something happened and it crashed. So. Okay. So after that, obviously you do the osteotomy through the osteotomy jig. We recommend performing an incomplete cut. If you want to complete the cut, that's okay. That's really optional. After that, you use your rotational jig. Your distal wire that you were using with your osteotomy jig, you use it to slide the rotational jig through its 0 hole, and then you add a second wire through the hole with the chosen rotation. So in this case, this picture is just showing a 30 to 39 degrees of rotation, and then you remove the 0 wire. So then, well, if you did an incomplete osteotomy and the step before, you just complete the osteotomy now, and then you will have 2 wires that are divergent, and you just have to leave them parallel. Probably you've seen this already in some videos, and I will show them in a few more slides. How do you fix this osteotomy? We use 2 parallel wires, one very plantar and one very dorsal. The second step is we apply the plate, and we fill the plate holes with olive wires, as you can see in the picture on the right. Then we add the interfrag screw, and then we replace the olive wires by the locking screws. Something very important is that the metatarsal should have a bone step here. So this white circle should be a little bit more lower. I don't know why it's just not really showing what I wanted to show you, but there should be a bone step here. That means you are keeping the same metatarsal length. If you are not leaving any bone step and this dorsal part of the osteotomy here, it means you're lengthening the metatarsal. And if that step is more than 2 millimeters, it means you are shortening the metatarsal. That is really something that we want. I mean, it's something that it's desired sometimes, but you should know what this means. And finally, you should shave off any bone steps on the osteotomy if there are. They should not exist, but sometimes you have small bone steps because you have to have a good plate to bone apposition. So this is how it should look like, your X-ray. It depends if you shorten it, if you lengthen it, whatever you want to do it, but you should have a good rotation. And just look at the metatarsal head on the lateral surface. You should not be able to see the condyles here. If you see that the sesamoids are a little bit laterally displaced, that's okay. That it's because you did some kind of capsulotomy or you open it medially here, and that normally gives you a lateral translation of the whole capsule and with the whole sesamoid complex. But after you suture and you reattach all the capsule, the sesamoids will slide back below the head. So this is a video we really did yesterday. That it's a continuous video, well, without any stops, that will show you how we really fixate the osteotomy once it's really performed. I hope you really can listen to the audio we recorded. So Keith, if the audio is not really well, please tell me, and I will just mute it, and I can just talk to you while the video is playing.
Sounds good.
Recording. So many people have asked us about how to fix the osteotomy. So this will be a continued video without any cuts. So you will see how we do it. It's just one way. It's not the right way, it's just one way. So you see here, it's the osteotomy complete, absolutely free, with no soft tissue attachments. So as you see, it was like here. This is a 42 degrees osteotomy. So this is the versions of the wires that we will leave parallel, like that. And we'll fix it in that position. So if you have a hand, an extra hand, that helps a lot to hold the foot, because when you do this rotation, you really need some lateral fixation with somebody's hand. So this is the original position. Just rotate, and if you want, you can slightly pull this wire, and you just fix it in a position, desired position, like that. Always dorsally, the one of these. You have to see a step here on the proximal fragment. If there is no step like that, you are lengthening the metatarsal. So you should have that dorsal step there. So once you leave it there, I start plantar with rotation. So then you can just leave it loose a little bit, because you already have some point of fixation. And then you go from dorsal distal here, trying to be parallel to this wire you just drove. So you can see how not that difficult. We fixated the osteotomy with 2 wires. We'll take a look at the X-ray now, but that's it. If you see that there is some kind of problem and the osteotomy is loose, you could add a 3rd wire percutaneously. You could drive this wire percutaneously too, if it's too close to the skin edge. So I hope you really could listen to that video. If not, we can just go through it again at the end. Just a few examples of some post-op views. This one, this case is a 30-degree rotation. As you can see on your left side, it's a complete, like a full circle. You could just draw a circle here, and it will exactly follow your joint line and your condyles. And this is another case with the 20 degrees, between 20 and 30 degrees of rotation, because you can draw a line following the joint line, and you really have you have another line. If you draw another line through the metatarsal condyles, you will have a small bone step, clearly less than 1 millimeter, but it's not a round line or circle line. So it's at level 2 rotation case. So finally, this is a last video I will show you, and then Emilio will proceed with the cases presentation. We don't like that circle there. Just give me 1 second. Okay. So here we go, guys. So this will go through a case. This is a homemade video, so please don't expect a high quality, high definition Warner Brothers production or something. So it's just a locally performed video. So probably these first steps, you already know them. So this is the first step that I showed you. So you got the wire going parallel to the floor and at 90 degrees to the metatarsal, starting 1 centimeter distal to the joint, as you can see in that X-ray and in those drawings. Then you slide the positioning jig on the 0 hole, right, in that video there. And you add another wire through the desired or chosen rotation hole, leaving you with that image. Then you apply the cutting jig, choosing the hole that you calculated with your promo table, and fixing it distally on the metatarsal equator. You can finish the osteotomy freehand without the jig if your saw blade is a little bit not too long. Remember to free up all the soft tissues at the osteotomy level, dorsally and plantarly, so you will have a completely free rotation of your metatarsal. Then you apply the 3rd and final jig, that is the rotation jig. As you can see, we do a small incision. It's normally at 3 centimeter incision, sometimes 4 centimeters, because we do the rest of the surgery with poke incisions using a Shannon burr. And then you have to achieve that those two wires should be parallel. So that's a video, one of the fluoroscopies we're doing. So you just have to look at the IMA angle and at the rotation that should be corrected completely. This is another example. I really like the music behind all these videos. Then you just hold, as I showed in the video, you just hold it with the clamp while you fix it with two wires. One coming from dorsal plantar and one from plantar to dorsal, or the other way around. And then you add, as you can see in that image, and then you add the plate. Oh yeah, you have to remove any bone steps. So the osteotomy, as I showed you before. And then you apply the plate immediately, as I already explained you. No, we'll fill the plates with the olive wires. We just fill the plate holes with the locking screws, and we'll remove the dorsal step at the metatarsal osteotomy level. So that should be an image that you should obtain at the end of the surgery with a pretty well aligned bunion. So Emilio will proceed now with the presentation. Just give us 1 second.
Okay, so thanks for listening. So we will show you some cases which will really just try to highlight how we measure the rotation, because we really think that this technique is very straightforward after you are able to fix it, as Pablo just showed. So for example, this case, this young female, we measured 15 degrees of IMA angle. So what about the rotation? So if you take a look at the lateral border of the metatarsal head, it's not a completely round head, although it's difficult to measure a formal step, but it's not a completely round circle. So in this case, we get into the level 2 deformity Pablo was telling you about. So it has to fall in between 20 and 30 degrees of rotation. So then we get into our table and we perform the osteotomy. So every time, as he said, we take a very close look at the TMT joint. So we're very scared of the TMT instability, a really pathologic instability. So every time we take a look at the AP and the lateral, and we try to rule out any sort of abnormal instability. So this is the same patient with the correction. Some of these cases, these are open cases. We'll show you some this late time, this last year, we've been developing this hybrid way of fixing, doing a promo and an MIS technique at the exostectomy level and at the ACAN. So this is another case, a 54-year-old female. So again, this is a very smaller IMA angle of only 11 degrees. So again, what about the rotation? So you can see that again, you cannot draw a perfect circle around the lateral aspect of the head. You can see that there is a small step. So the step, when you see it is small, you know you're in the range of 20 to 30 degrees. So you may end up looking at 1 millimeter or fractions of it. The important thing is that you fall into that range of deformity, into that range of pronation, and then you choose the 20 to 30 degree of rotation column in the table, and then you can choose the correct osteotomy angle. So this again is the pre-op and the post-op view, again with a promo. So another example, 45-year-old. In this case, we measured 15 degrees of IMA angle. So in this case, you see, again, it's not perfectly rounded. We see that you can measure a bone step. Again, this is the most frequent case. We fall into this 20-degree moderate deformity case. So this osteotomy is planned, as you can see, considering a range of deformities, considering the rotation. So with one, in this case, moderate rotation value, you can solve in between 20 and 30 degrees of rotation. And in this case, you can see already there's a bone formation, callus formation at the osteotomy level. Let me show you another case. So in this case, take a look at the lateral side of the metatarsal head. Although you can see here a double density, a line that may tell you that there's a step, you can follow the head that it gets completely smoothly into the curve of the metatarsal condyle. So for us, this is a circle, and so that in this case, we will consider this a level 3 deformity, so 30 or more degrees of rotation. So we choose the osteotomy angle accordingly. And this, I think this example was shown to you already by Pablo. There are some cases with less pronation, as this case. You can see that in this case, we measured 12 degrees of IMA angle. And what about the rotation? Clearly, there's no complete circle. And indeed, if you try to measure the step in between the metatarsal condyle and the joint line, the step will measure more than 1 millimeter. So for us, this falls in the level 1 deformity, so between 10 and 19 degrees of rotation. So as you can see, we have a lot of examples for the moderate deformity cases. We also have a lot of severe deformity. In this case, these are the less frequent cases we have with only 10 to 19 degrees of rotation deformity. And what you can see here, I am pointing it with the mouse. So this is one of these cases in which we did the proximally, and we are doing the exostectomy, and we already did the aching with an MIS idea. So this is always trying to do it less aggressive, minimizing skin incision. And we think our patients are pleased with this idea of decreasing skin incision, although they will get anyway the same bone edema, the soft tissue edema and swelling around the foot. They see a smaller incision and they are grateful for that. I think this is the last case, just to show you a final example. See how the metatarsal head looks like. It's not a perfect circle, but you are not able to measure a formal step. But this is, I think, was already shown by Pablo. As the line is not continuous, there's a discontinuity in the line in between the condyle and the joint line. We consider this to fall into the moderate deformity cases. So then we assign it a 20 to 30 degree of rotation deformity, and we choose the osteotomy angle. And this is the correction. So again, small aching and the promo fixed at the metatarsal level. And okay, so that's the end of this small series of cases. We wanted to show you mainly to make clear how we're trying to figure out from the AP X-ray the amount of rotation. And as Pablo already told you, we will publish shortly probably the relation in between the AP and the weight-bearing CT scan. So I don't know if we have any questions or comments, or maybe you can use the chat or through the audio. I don't know.
Yeah, that was great. Thank you both, Dr. Pablo and Emilio. There were two questions that came up during the presentation. The first one, do you mind just reviewing kind of your, as far as the TMT instability goes, just as far as those steps in the physical examination, is there anything else you're doing or other X-ray measurements to help determine that TMT instability?
Yes, so besides measuring any sag on the lateral X-ray, any step on the AP X-ray, one other thing we measure on the lateral X-ray is if we see a divergence between the dorsal cortex of the first metatarsal compared to the second metatarsal. So every time we see a lateral X-ray view of the foot, we should see that the first metatarsal dorsal cortex is pretty parallel to the second metatarsal dorsal cortex. So when we don't see that and we see a divergence, so that like the first metatarsal starts to go up, we always take a look at the other side. That also may tell you about tarsometatarsal instability, what we think is abnormal. I mean, if it is symmetric, no pain at physical exam, and no step or sag on either X-ray views, then we will consider it to be normal. But if there is any asymmetry, and I tell you this matter of divergence between these two cortical lines is one other factor that makes us think in a pathologic TMT instability.
Fantastic, thank you. And then a couple more questions rolling in. Can you maybe comment a little bit on whether or not you ever do a lateral release or a modified McBride?
So over the years, I've started doing lots of proximal osteotomies back around 15 years ago, and we always thought that the main thing was to put the first metatarsal head over the sesamoids and to place it and shorten it as needed. So over the last few years, especially this last year, we've seen that it helps in doing a smoother and easier correction to make some release of the adductor tendon. We think that the capsule is the most important thing we have to release. Maybe in some cases, probably in the most severe, more deviated Hallux Valgus cases, the adductor tendon plays a role, not in allowing you, not in getting a perfect correction of the first metatarsal, but maybe, especially cosmetically speaking, to get a very well corrected MTP angular position of the hallux. So we do consider it in severe Hallux Valgus deformity. We do it in a MIS way, but we're limiting it. We don't do a formal open lateral release, releasing the intermetatarsal ligament, the capsule, and the adductor tendon. We just do a small incision, and we try to release the lateral attachment of the adductor tendon. So we do consider it, but mainly in severe cases. What do you, Pablo, maybe you want to add some opinion?
Yeah, so I would just comment that if you do a lateral release, probably for those who do that, probably they don't need as much as we do an aching osteotomy if you do a formal lateral release. But you, in that case, you do need some very cautious dressing, apply very cautious the dressing and change it probably yourself. You cannot rely on somebody else, because to achieve a perfectly aligned metatarsophalangeal angle and relying only on your dressings, well, that's something that you should really be careful with. We do not rely so much on soft tissues alignment, and we prefer to lift the bone perfectly straight and the toe looking pretty when we go out of the OR, without having to put any dressing or any bandage around the big toe to achieve a perfect alignment. So that's why we, most of the cases, we perform an aching osteotomy. But if you do not want to do achings, or you don't like to do them, etc., that's perfectly fine. But in those cases, you have to do a lateral release, and you have to keep it in the perfect aligned position with bandages or dressings or whatever.
Great. And then as far as some of your post-op X-rays, there's some still look like some lateral deviation of those sesamoids. When you're doing your reduction, are you mostly looking at just the sharpness of the lateral side of the met head to determine when you're finished, or are you really trying to get those sesamoids centered?
Yeah, so we focus on the shape of the metatarsal head. So if you perform the osteotomy following the principles, you will get a perfectly aligned bone. And as Pablo said, if after making the capsulorrhaphy, you don't get a good position of the head over the sesamoids, we many times and most of the time see that happen during the post-op period, when the patient recovers muscular tension, because that also depends on the abductor hallucis muscle regaining tension. So we accept some lateral displacement, but we don't accept any malreduction of the metatarsal head, considering the lateral shape.
Great. Then looks like we have one more question just about looks like the when you're talking about um, or shortening and lengthening the metatarsal if there's not that step off. And if you ever do get in a situation where you find yourself over lengthening and you try and plantar flex that capital fragment, do you find that it ever gets bound up at the MTP, or how do you get that that capital fragment to where you're not over lengthening?
So as I understood the question, we never lengthen the metatarsal bone. What we try to do is to keep the same length or shorten it a little depending on the severity of the deformity. So if we see a huge deformity with a very high, over 35 to 40 degrees of NTP angle, angular deformity, in those cases we use the jig, which has 3 parallel slots, to make a very precise shortening, and through that cut we allow some shortening, because in that way we can release the soft tissue tension at the NTP level. We don't regularly would plan in lengthening the metatarsal bone. So the question regarding lengthening, do you have, can you maybe repeat it or make it more clear, because we don't.
So say that one more time.
So we don't regularly lengthen the metatarsal bone, so we always keep the same length, or we shortening a little depending on the severity of the deformity. So my question to your question, maybe I didn't understand it. We don't lengthen it, or the question is, do some of the audience do lengthen them or would like to lengthen the metatarsal bone?
No, I think so. If you are in a situation where you feel like it is being over lengthened, so just kind of, I guess, go over where that the step you were looking for. You said 2 millimeters step off on the proximal fragment is what you're looking for.
Yeah, so that's correct, Keith. I think that it's very hard to over lengthen it, because everything gets really tight. You should be really strong to lengthen the metatarsal, because normally the foot will not allow you to do that. So normally you have to fight not to shorten it too much, but to lengthen it too much. We have never been encountering that situation. You can be sure that all the soft tissues will constantly fight you, and your hallux valgus angle will be very tight, and it will be very hard for you to correct it if you over lengthen it. So that's really not an issue for us, we think.
Right. I think let me just check, see if there's any other questions. I think we're all set. If anyone else does have any questions, or if I didn't get to any of your questions, I'll be sure to get in contact with you. Feel free to email myself. My email is kprice@paragon28.com, and I'll make sure to get those answers to your questions.
Yeah, absolutely. We're totally open and happy to receive any question regarding this technique or indications, or to discuss maybe an indication for any clinical case anyone may have. So please feel free to contact us.
Thank you all so much for your time, and thank you both, Dr. Pablo, Dr. Emilio Wagner, for your time tonight. That was great, and please, everyone, have a fantastic evening. Thank you for joining the call.
Okay, thanks.